Great. Well, nice to see people rolling in. Good evening, Christine, Judy. Hi, Lynn. Hi, you, Tracy and Debbie. Nice to see you. I always want to say to see you nice after that, which is a very old British TV comedian, Dr. Shelby. It was his catchphrase. Nice to see you nice. And we all grew up with it.
Who is it? Who's the comedian?
Hey?
Who was the comedian?
Bruce Forsyth. No. He hosted Strictly Come Dancing, which became, of course, Dancing with the Stars.
I know, yes.
Yeah. Bruce is an institution in the UK. Yeah. Well, look at this. Lovely. Thank you so much, ladies, for joining us. Hello, Claire. Hi, Imani, Rowena. This is wonderful to see you. Welcome to Harley Street at Home, our very, very special sleep masterclass, which I am particularly excited about because we have two really exciting presenters and experts with us tonight who I'm going to introduce you to. You might have already seen us talking about this evening on Facebook and Instagram. We've been all over. We've been on tour this week. So let's get started. I'll actually also just bit of housekeeping. We've got time for Q&As. We absolutely would love your questions. I've got questions that ladies have already emailed in that can't make it tonight. So it's one of those, ladies, if you've got questions, get in quick. There's several ways you can do it. We've got the chat room, which I will open up. There you go, chat's up there. You can pop your questions in there. If you are feeling bolshy, you can just turn your mic off and ask it. We don't mind that. And if you are feeling desperately polite, which won't be like you can go into the reactions button there and you can just raise your hand and I will, come to you in turn. But, it is one of those, do not wait for 5 to 8 to ask your question, because once the questions start, they will really fly. So let's introduce our experts to you this evening. First of all, let me introduce you to Dr. Shelby Harris. She is in private practice in White Plains, New York, where she specializes in the use of CBT, cognitive behavioral therapy, for anxiety and depression. She is board certified in behavioral sleep medicine by the American Academy of Sleep Medicine and treats a wide variety of sleep disorders. Excuse me, using evidence-based non-pharmacological treatments. Before going into private practice, Dr. Harris was the long-standing director of the Behavioral Sleep Medicine program at the Sleep-Wake Disorder Center at Montefiore Medical Center. Dr. Harris currently holds a dual academic senior level appointment as clinical associate professor at the Albert Einstein College of Medicine in both neurology and psychiatry departments. He's published and presented research on the neurophysiological effects of insomnia in adults, as well as behavioral treatments for insomnia, parasomnias, narcolepsy, and excessive daytime sleepiness. She is frequently invited by hospitals and organizations to give grand rounds lectures and experts. Dr. Harris is also the author of The Women's Guide to Overcoming Insomnia, and I believe she has a cracking recipe for flaky pastry that she'll share with us at the end.
I love to bake, so there we go.
Now, next to Dr. Shelby Harris, we have a friend of Harley Street at Home, Dr. Zoe Schaedel. Dr. Zoe holds the Advanced Certificate in Menopause Care, the highest level qualification from the British Menopause Society. She is a British Menopause Society accredited specialist and she trains the menopause specialist. So you don't get better than that. Zoe has a special interest in sleep and the menopause, and recently presented at the British Menopause Society conference just a couple of weeks ago, and she was brilliant. Zoe sees patients from all over the UK and currently practices from the Women's Health Centre in Sussex. We are really lucky, ladies, to have you both with us, particularly not just because you are so brilliant at when it comes to sleep, but also because I think you just have natural gifts for making something which is quite tricky, quite complicated, actually really simple to understand. And so I thank you for that. I guess the first question we've got to ask is because, and the reason we've put this together is sleep must be one of the biggest issues that troubles women in Harley Street at home. It's something we see all the time in our Facebook groups. So what I want to know to start with is what happens to sleep and why does it happen? Is this just something that happens because we get old, or is it something that is actually specific to menopause? Zoe, do you want to start, and then we'll get Shelby's take on it?
Yeah, and thank you so much for that lovely introduction, and thank you so much for having us today. I'm really looking forward to today. So what goes wrong with sleep? So for women in the menopause or the perimenopause, sleep often becomes disrupted. Even if they've been good sleepers all their life, you might start to notice that you wake up more at night, or you struggle a little bit more to stay asleep or fall asleep. And actually, the statistics say that 40 to 60% of women during the menopause transition will have disrupted sleep. So it's kind of half of every woman from their mid-40s, which is a lot of women. And there's lots of things that cause that. So it's not just one thing, and everyone will be a bit different. But what we know is that hormonal variation that occurs in the perimenopause can affect sleep. So as we know, there is estrogen receptors all over our body, and the sleep centers of our brain aren't an exception to that. So there are some issues when estrogen starts to go a bit haywire. You start to get impact on the kind of regular sleep that we might have been used to before. And also progesterone. Progesterone we don't talk about as much in the menopause. We talk about estrogen a lot, but progesterone falls before estrogen falls. And it's one of the things that happens quite early in the perimenopause. And we know progesterone is really helpful for sleep. So actually, there's not so much research about it, but that's probably something to do with it as well. And then there's the symptoms of the menopause. So if you have, hot flushes and night sweats, as 85% of women will, they're very likely to wake you up at night. That we see that a lot. And things like getting up to urinate in the night can obviously disturb sleep. And some of the changes to our mood and feeling more anxious that can happen to some women in the menopause can also really impact on sleep. But it's not just those things. It's also often a time of life that's very busy, and there can be lots of stress and other things like that around, which can all impact. So it's a bit of a kind of anti-sleep soup. There's lots going on that can disrupt sleep.
Great. Okay. So clearly there is a hormonal connection. There is probably a connection if you're bothered by symptoms that trouble you at night. Yeah. What about actually just how we think, how we feel, what we do, Shelby? Has that got anything to do with it, or is it all hormones?
No, 100%. I always think of it like almost a Venn diagram of three different situations. So you have, in women, we have the biological changes that are happening, like was just mentioned. Then on top of that, we have the psychological changes that happen. So for a lot of women that are going through perimenopause, there's increases in stress, anxiety, depression. We start seeing more of that. We start seeing a racing brain that's happening a lot more. A lot of the women that I work with will say, I can't turn my brain off at night, or they wake up in the middle of the night and their brain is on fire. So there's a lot more of that. And then the third area, which we was just kind of briefly mentioned, is like there's also a big social and demands stressors. So a lot of these women are in their 40s who are starting to go through this, and women are having babies later on in life now. So a number of people are either have young kids at home, or they have young kids, they're working on top of that, they're taking care of the household. And a lot of times people who are going through this also have parents who are aging. So not on top of just the household duties and work, you're dealing with younger kids sometimes, older adults. It's just a firestorm of concerns and worries socially that then make us not be able to turn our brains off. Then we wake up and we're thinking about anything and everything, and then that creates more of that firestorm.
So we've got, again, hormones, symptoms, plate spinning, could we call it that? You know, just 21st century living. You think back, ladies, to your mums and your grandmothers. Were they doing all the things that you now do and expect to do, and the world expects you to do at this phase of your life? You know, the days of going off into a dark room when perimenopause hits and coming out when it's over have gone. There is a lot that we need to keep doing. So how specifically do sleep issues manifest at menopause? Do they show in a different way to the way they might when you're younger?
One of the things I was just thinking when you were saying that was, of course, all of these demands and stresses and everything that women have to cope with, it's made even harder when you're not sleeping. And so actually the women that we see are often they talk about nighttime and how hard it is to be awake, but also it's about the impact on the daytime. So actually that's what we are often working with, which is women who not only are not sleeping, but are feeling totally exhausted and fatigued in the day. And I think that's often really what we're focusing on, is how people feel in the day and how they're impacted on. And actually, once you've had sleep, poor sleep's going on for a while, you can start to really feel quite isolated with that and start to withdraw from things, feel quite lonely, it can affect your mood. You can start to feel quite low. And it can also affect the way, your memory works. It's harder to remember things when you're underslept for a while. And so not only are women dealing with kind of menopause symptoms, they're also dealing with the impact of poor sleep on their daytime. So often that's what we're really, really focusing on.
And I'm guessing, Shelby, you're going to see the effects of the lack of sleep and how that affects people, and just how it affects their general performance, their ability to cope.
Yeah, their ability to cope. It's that stress tolerance, right, is a big issue. So if you're feeling more depressed, more irritable, more anxious, you're not going to be able to tolerate the same stressors that you may normally be able to do. And then what happens is you get to bed, you still have all these things in your brain that are spinning, and then it makes it harder to fall asleep or stay asleep. And then the same thing tends to happen more and more. And what we're seeing in research is that we really need to focus on the sleep component, because if you focus on just the daytime depression or anxiety issues or stress without getting that sleep part of the equation figured out, then you're only treating a piece of the puzzle, and you need to be on a better baseline with sleep in order to really do the things you need to do behaviorally or medication. We find that it impacts all those treatments for depression and anxiety if you're sleeping better.
Brilliant. Okay, thanks, ladies. I'm looking at your questions. They're coming in. Do not worry. I'm going to put these to our experts. So are we able, because I think it's ever so easy. My husband counts his hours, and my goodness, when we get to the weekend, what a performance we have on the hours we need to catch up on. For goodness sake, if life was only that simple. Do we know actually how much sleep we really need?
Well, I think there's a variation in the amount of sleep that people need. So there's that idea of it's the 8 hours, you have to get 8 hours. That's really because the majority of people are somewhere between 6-ish, 7-ish, and 9 hours a night. So 8 basically falls in the middle. It's just easier to report in the studies or things that you'll say, people will say online. So it's really a range. And what we try to figure out in the area of sleep medicine is we want quality over quantity first, because I think people get so fixated on that 8 hours that the more you paint it in gold and put it on a pedestal, you put pressure on yourself to get the 8 hours and then you end up falling short. So what we try to work on is better quality sleep, even if I'd rather someone get 6 hours of better quality with a quick awakening but going back to sleep than broken 8 hours. So that's really, and to know that there is a range, it doesn't have to be exactly 8.
Absolutely. It's really variable. And I totally agree. This fixation on hours, tell your husband it's not about the hours, it's about the quality. And actually having even a slightly shorter amount of good quality sleep, I would take any day over really trying to achieve that longer sleep. It's really important. And also it's worth saying, you know, people really vary with what they need. And I would never tell anyone the amount of hours they need. It would be about them telling me, how do you feel? What do you feel? Do you feel you've had enough sleep? And actually, some people do feel okay on 6 hours sleep. Some people they need more. And it really depends on the individual. So no sort of arbitrary targets and numbers. And also we know we sleep a little bit less as we get older. So it is worth saying, you know, even if you used to be someone that would always have 8 hours sleep, it is true, just like other things in the body that age, our sleep centers also age a bit. And actually that means it's harder to get exactly the same sleep as we get older. So we might sometimes, you know, do well accepting just a little bit less, as long as we feel we're getting good enough quality.
But the key here, like you were saying, it's a little bit less, because a lot of times people will come to me and say, well, I'm getting half the amount of sleep I used to get, but I've been told it's normal as you get older. It's a little less. The difference is that it's definitely more broken and not as deep as you get older, for sure, too. And that people tend to nap a little bit more. So if you find that it's a lot less, you're doing worse, talk to your doctor. Don't let someone just tell you it's aging. But it is normal, like you were saying, to get a little bit less. It's a spectrum for everyone.
So I guess, I mean, the 8 hours sounds a bit like 5 fruit and veg a day. You know, it's something that's just easy to kind of put your head, 10,000 steps, all these kind of things. Okay.
And piggybacking, if I can add one quick thing.
Yeah.
On that are all the trackers. So if you do find that you have insomnia and you have trouble sleeping, which we'll definitely talk about in detail, the trackers that say you didn't get a perfect night, you didn't get 8 hours, it just makes people with insomnia more hyper focused on their sleep and actually worsens it. So there's research out we call it orthosomnia, where those trackers try to get you to some goal and it actually makes it worse. So if you have insomnia, I actually encourage you to let go of the trackers. They're good for some people, but not people who have trouble with their sleep.
Getcha. Yeah. Okay. I'm also just texting my husband now saying it's quality, not quantity.
There you go.
Do you know what I'm saying? Yeah. Okay. Right. Now. Okay, now we can all say, and we're seeing in the comments here, you know, some people are talking about that they've got kind of disrupted sleep. Other people are saying, look, I sleep, but I just feel rubbish when I wake up in the morning. I don't ever feel rested. Other people are saying, look, I wake and then I'm lying there for 2 hours and nothing's happening. And so how do you know what's a problem versus, you know, just a bad night's sleep? When is your sleep kind of being something that can almost carry a label to say this is now a problem?
Dr. Zoe, you want to take it?
Yeah, well, we can make a diagnosis of insomnia. So it's really interesting. Often when we talk to women in the menopause who say their sleep is poor with the menopause, actually, when you dig a little bit deeper, they fulfill the criteria for what we call insomnia disorder. And I think it's really important to make that diagnosis. So actually, even if the menopause has triggered it or started off the problem, what they're actually suffering from now is insomnia. And we know it's insomnia if someone struggles with their sleep, so they wake up in the night or too early or struggle to fall asleep for 3 nights a week for 3 months or more. So actually, it's not that long. And the majority of people in the menopause who struggle with sleep, the problems will go on and on for much longer than that. And so then, even if it started in the menopause as a result of the hormones or symptoms or whatever, it's still really important to say, look, this is actually insomnia now, and we need to treat that in its own right and really help with your sleep. It's also really important to think what someone has made a comment here about that had an issue with snoring. And I just think also it's worth saying, Menopause and insomnia are incredibly common, but they're not the only sleep disorders out there. And it's always worth being aware that sometimes in menopause, other sleep disorders can become more common as well. And something called obstructive sleep apnea is something where it's a restriction of your breathing at night. Sometimes there's a bit of an obstruction at the back of the throat to stop the air going in. And actually, that becomes more common at the time of the menopause. It doubles. And it can mean women feel really sleepy the next day. And it can also cause people to wake a lot through the night. And often you do have snoring with it and lots of little wakings in the night and sometimes headaches. But women don't always present in the classic way. And so they may just present as having more nightmares or having more wakings, or feeling more anxious in the day. So it's always worth, if you think you might be suffering with any of those symptoms, particularly if you've had some snoring or something like that, definitely speak to your doctor about getting checked out for sleep apnea.
Yeah, and I think also is on top of that is there's restless legs can worsen a lot of times too. So that feeling I've been experiencing it a lot lately. So like your legs or your arms, it doesn't have to be just your legs, feel like they're just moving. It's creepy. You have to keep stretching, and we see that a lot with hormonal changes too. So that can look like it's insomnia. A lot of times you have trouble falling asleep, but it's mostly because you can't lay still. So people might report that they feel more agitated or anxious, but it's really a biological thing that's happening for a lot of people. And then also the sleep apnea we see a lot of times too, but people are misdiagnosed as having nocturnal panic attacks sometimes too. So you can have panic attacks and nocturnal panic attacks, but sometimes people are actually just choking and gasping and waking up and they're feeling out of breath and their heart's racing, but it's not really actually anxiety, it's sleep apnea that's causing it. So it's always a good idea to have that evaluated if you need to.
Gosh, yeah. I mean, there's a lot going on. Restless legs drive me crazy. Oh, sometimes you just want to be like hung from your legs to stretch them to stop it, don't you? It's just horrible. Can I just ask as well, because sleep apnea, I think, has a label or a suggestion that you've got to be obese to have sleep apnea. Is that true, or can anybody struggle?
No, not at all. So anybody can struggle with sleep apnea. You're more at risk if you're overweight or obese, just because of the pressure on the airways that can come with that. But actually, I've got patients with sleep apnea who are skinny, who are, middleweight. It can happen to anyone. So you mustn't rule it out. If you have any of the symptoms you're worried about it, do get it checked out, even if you're not overweight. It's a risk factor, but there are lots of other risk factors.
And it doesn't mean that you can't, if you have sleep apnea, you don't have insomnia, right? You can have, we call it comisa. You can have both comorbid insomnia and sleep apnea. You can have them together, but it's that quality over quantity thing, right? So I have patients that I will get sleeping more deeply, or they think they're sleeping more deeply, but then they feel so tired during the day. It's because they have untreated sleep apnea. And then we're trying to get them actually evaluated for that. So it's definitely things you have to think about as a whole picture with different components, but get the evaluation for apnea if you really are suspicious.
Okay, thank you. Right. So, I mean, I think it's pretty clear the causation is really complex. The manifestation is really complex. So I'm imagining the way we're going to treat this is not a one size fits all. We use that term so much, but we need a very holistic approach, which is, of course, where your expertise really comes in. Can we start thinking then about what some of the options are? And ladies, these are not recommendations. These are just the sorts of things that Dr. Zoe and Dr. Shelby might explore with somebody who's struggling. How can we do it? Do we just throw medicine at it?
So I'll start just with a little bit about hormone therapy, but it's an option. So for women who can take HRT, if those hormonal changes have thrown off the sleep, it can be helpful to replace them. And actually, it can help because it gets rid of the night sweats, and it can help because it makes you feel a bit better in yourself. But also, sometimes it just helps because it helps the sleep and the sleep alone. And what we know is sometimes that's estrogen, but more often it's when you add in that progesterone as well. So progesterone, There's lots of different types of what we call progestogens. Some of them are synthetic and one is natural. And actually, the natural progesterone has a lot of evidence that it's more helpful for sleep. So it works on our brain very similar to some sleeping tablets, actually, but without the sort of downsides to them. So that can be very helpful. So if someone is struggling with sleep, I would always offer them the kind of HRT that has that natural progesterone, if that's the way they wanted to go. So it's worth knowing that's an option. Yeah. But it doesn't always work.
And would you take that element of your HRT at night?
Yes. Yeah, you always want to take that at night because it works on the brain in that way. It can make you feel a bit drowsy. So you never want someone taking that in the daytime.
You know, there's so many women are never told about that.
Interesting.
Yeah, that
you feel really groggy. It can make you feel really groggy. Yeah.
Yeah, no, I had a friend visiting this weekend and she was talking about, you know, I love my HRT, but I'm just shattered all day. And I got into some, what are you taking? And then she told me Utrogestan. And I said, when do you take that? In the morning. And, you know, suddenly, of course, I got above myself and I was like, no, we need to have this at night, you know, because then she's worrying about sleeping. But yeah.
And actually, it might help sleep better. So most women are told to take it right before bed. But actually, if you take it with your evening meal, you absorb it slightly better and it has time to work. So I do sometimes say that to people. If falling asleep is a problem, take it a little bit earlier, take it with food, you absorb it a bit better and it can be really effective.
Fantastic. Right. So that looks at the hormones. Shelby, do you want to talk a little bit about either sleeping pills, something I've also heard a lot about, melatonin, things like magnesium? What do we know about these?
So there's really, when we talk about melatonin, there's a little bit of research on it. It's beneficial at some points. We do know melatonin rate levels drop as people age, but it's not a panacea that everyone thinks it is when it comes to sleep. So I see all the time people are just told, take melatonin, take melatonin. And in the United States, it's not regulated by our FDA. So there's no governing body to actually say this is what is in the bottle. And also people just take way too much of it. So what we usually recommend is about an hour before bed, if you want to try it. Anywhere between 0.5 milligram and 3 milligrams is kind of the standard dose. We use it differently for different sleep issues. But for insomnia, like I said, it doesn't really work for that many people. And if you're starting to take more than 3 milligrams to try and get the same effect or try to get to sleep, it's not working for you. And magnesium is a very calming supplement. It does help with some people, but we just don't have tons of research on it to make them like standards as recommendations.
Yeah.
And also the thing for people to know too is that if you're going to try a supplement, it doesn't mean that it doesn't have side effects, right? So people come to me all the time and for nightmare treatment, and then I look and I see they're on melatonin, and melatonin is a big culprit for nightmares. So we try to stay away from that. And then when it comes to sleeping pills, so things that are more prescription based, I'm sure Dr. Zoe can talk a lot about that aspect, but we've tried not to use it initially for a lot of people because the reality is they don't work very well long term for a lot of people. People often feel more groggy during the day. Remember, the goal is to be able to sleep so that you can feel better during the day. And if you feel worse, even with a good night's sleep, what benefit is that for you? So it doesn't mean that sleeping pills don't have a place, but we really try to do things like cognitive behavior therapy, which I know we're going to talk about. We try to do more behavioral and psychiatric or psychological treatments that are non-drug treatments that really have the same amount of, or have more evidence that they're effective in the long term behind them.
Absolutely. And again, just on that prescribed sleeping pills, you can have sleeping pills prescribed. And I see lots of women that are really worried because they've been taking them for a long time and they know they're not so good for you in the long term. But more importantly than that is just they're not very effective. So they're only licensed in this country for use up to 4 weeks. And that's because they're actually relatively good in the short term. If you've got a crisis and you really need to sleep and you need to get through this, that's a good time to use them. But what they don't do is fix your sleep problem. Whatever is underlying that sleep problem, they just cover it up. So it's a bit like taking a blood pressure tablet for your blood pressure. As soon as you stop that, your blood pressure will go back up again. And it's exactly the same with sleeping tablets, but they don't keep their effect over the long term. So you're left with nothing that helps you. So they really just aren't great. We wish they were. We wish they work well, but they don't. And so there's other things that are more effective.
Sure. They're like Elastoplast, laxatives, all those things. We get used to them. Yeah.
Whenever I start off someone on a sleeping tablet, which I sometimes, you sometimes need to do, we talk about the exit strategy. What's going to happen to mean you can stop these really safely and it's not going to bother you. You're going to do other things to fix the underlying problem.
So they're only allowed 4 weeks?
Mm.
That there's no regulation about that in the US.
Yeah, so that's the license and the guidelines. However, Shelby, what the research suggests is that more often than not, they're prescribed off license for much longer. So yeah.
Right. So, and with things, just coming back to the melatonin and the magnesium, because again, we have hundreds of women using magnesium and talking about it here. Yeah. My take on this, and I'm the same. I sit the same as you guys. That we don't have that evidence. Now, it doesn't mean these things might not be helpful. It's just if the evidence hasn't been done, we can't say this isn't a public health message. Yeah. What I would always say is, if you're going to start something like a magnesium supplement, don't expect a miracle. Give it 3 months. If after 3 months, 12 weeks, nothing is happening, it ain't going to work. It's not suddenly going to improve. If you think it's helping, great, keep going.
I'm going to be slightly more negative than that, just slightly. I really agree with your take on everything, but there have been studies done on magnesium, and and none of them really show an effect on sleep, particularly for people with sleep problems. So what we haven't done much research is, if you're out there having relatively good sleep, can magnesium make that a bit better? I don't know. But if you've got a sleep disorder like insomnia, does magnesium help you? I don't think there have been studies and they don't show it does. And there are small studies where women were in nursing, actually women and men were in nursing homes, and they were magnesium deficient. They showed they were deficient, and giving them magnesium did help their sleep, because presumably part of that deficiency was causing that. But most of the people we are working with aren't magnesium deficient. So I don't really recommend it. And the other thing with people taking supplements, so I'm very happy for people to try anything. If it helps, brilliant, it's likely to be safe, go for it. But it can give you a sense of failure. Like, you can try. There are millions of things on the supermarket shelves for sleep, and you can go through them, and you start to think nothing is going to work. I'm past help. Nothing's going to work. And the thing is, they weren't designed for it to work. That's what I want people to know. These things are not made for people with problems sleeping. If they worked, you would have drug companies getting them on license and selling them, but they don't. So I want to say, if you want to take it, that's fine. But if it doesn't work for you, it's not you. It's not you that can't sleep. It's just that the treatment's not the right treatment.
And I also, just to add, I encourage everyone who wants to try those things to talk to your doctor about it too, because they can have interactions. Some of them have interactions with whatever medications you might already be on. So just because it's over the counter doesn't mean it's completely safe. Definitely talk to your doctor first.
One last thing on the magnesium thing. Ladies, magnesium is found in the earth. It's therefore literally present in everything we put in our mouths, whether it's a plant food, whether it's meat, whether it's dairy, eggs, it's everywhere. I don't think I've ever seen anybody with a magnesium deficiency, which is usually the reason to take a supplement. Okay, right. So now let's think then, kind of practical things that you might do again in a clinical setting. Let's hear a little bit about CBT, and then I want to think about, because then I want to sort of think about some things you could just do in the daytime to help, and things you might do in your kind of nighttime prep. But can we talk a bit about CBT first?
Sure. So CBT, cognitive behavior therapy for insomnia, is a evidence-based treatment that has been around for a number of years now. And finally, people are talking about it. It took like a number of years to get there, but it is the gold standard treatment for insomnia for most people. And it's, at least in the US, it's the American College of Physicians with their primary care. It is the first line treatment in sleep medicine, primary care. A lot of societies have that as the first line treatment because it's short term, meaning anywhere from 2 to generally 12 sessions. I don't even see people weekly. I see them every 2 weeks usually, sometimes even spaced out a little bit more. It's short term. It is very evidence-based, and it's giving people tools to help sleep better in the long run. So as opposed to taking a medication, then you stop the medication and your sleep gets worse, you actually have built in tools to sleep better in the long run. So the cognitive part is working on changing the thoughts, the pressure you put on yourself to sleep. So whether you're worrying a lot about sleep, I won't be able to function tomorrow, we work on that. We do some meditation if we need to. And the behavioral is changing sleep hygiene, changing bedtimes, wake times, what you're doing in bed at night, changing all that sort of stuff as well.
So it's, oh, I think Nigel might have frozen, but I think we should just keep talking, and I think he will find his way back to us. But I think what's really important is cognitive behavioral therapy that's targeted for sleep, for insomnia, is different to that for anxiety and depression. So in the UK, it's actually easier than it ever was to actually get some CBT for anxiety or depression. You can often access that through your primary care team. But what it's much harder to access is this really specific program for insomnia, and it is quite a different thing. And it's what we use also in the Good Sleep Clinic. So I, as well as being a menopause specialist, I run the Good Sleep Clinic, and we tend to use this because of those reasons. It really works, and it doesn't take a long time. And the other thing is, it's proven to be effective for women in the menopause. So actually, they've done lots of studies, and actually one of the biggest studies, women just had 6 weekly sessions using a telephone call, and actually it hugely improved their sleep, even if they weren't taking HRT and they were having hot flushes. Actually, it didn't only improve their sleep, it also improved the ability to deal with the hot flushes and how much they troubled them as well. So it's a really useful tool, isn't it?
And I think the fact that it says therapy in it, a lot of people think that they're going to weekly therapy appointments. It's not that way. It really is. People are very surprised when they see me for it. It's let's look at your sleep diaries, track your sleep, do this, do this, do this, report back to me in a few weeks, and let's see how it's going. But it is very targeted and extremely, like you were saying, extremely effective during perimenopause. So
it's very practical, isn't it? It's so one of the things about it is it's when sleep goes wrong, whether it's been caused by the menopause or depression or anything, when it goes wrong, your brain and your body form a kind of pattern or a habit, and you get stuck in it. And so it needs a kind of retraining. It's almost like a bit of personal training to get you out of that rut and rewire some of those pathways. And that's what the program does.
Thank you, ladies. I don't know if you knew I was tap dancing there. My laptop totally froze and I've moved onto my phone. So I was having literally palpitations. So
we were fine. We just kept talking.
Thank you so much. Where did we get to? Just
we were just talking about CBTI, which I know, you know, I spoke about it at the conference. You know, it's a very effective kind of program. And we were just giving a little summary.
Fantastic. Okay.
In combination with medications, it doesn't mean that you have to stop one thing and then start CBT. It just, it's really, we try to do it as the first line thing.
Fantastic. So it is part of that holistic approach. So then on a practical level, let's assume some of the ladies here are, you know, are wanting to go away tonight and just try something in their, let's start with nighttime, in their nighttime routine that could be an adjustment that might be helpful. What are the kinds of tips or the things that you look for when you're talking to a patient that give you clues that that nighttime preparation for sleep is kind of a bit messy and needs tidying up a little?
Well, I always ask, like, what's your wind down routine? And people are like, well, I'm doing a million things and then I'm just so tired I get in bed, or they're just scrolling, doom scrolling on Instagram or anything else. I'm like, that's not really a wind down routine. So there's a few things. I think you have to start thinking about the sleep as not being an on-off switch. It's a dimmer switch. So you need to, for that busy, busy brain, you need to like really dim your brain down essentially. So if you never have any wind down routine, start with 5 or 10 minutes. I'd rather you do that than nothing at all, or some nights with it, some nights without. So it could look like dimming the lights around you, creating a fake sunset, and doing something ideally without a screen. There's debate about how much screens influence sleep at night, but I also get sucked into what we're looking at, that it makes us stay up later or get our brain more active. So really try to find things that are quiet, calm, relaxing that you can do in dim light. 5, 10 minutes, working towards a half hour to 60 minutes before bed, if possible. If you can't even find 5 minutes before bed to wind down, we have to have a discussion. And then the other things to think about are we change sleep timing sometimes for some people. So a lot of women will get into bed when they are tired but wired. So they're tired, but their brain is busy. So don't bother getting in bed yet. We want to time, and this is where you can work with someone on, is try to time getting in bed with when you're actually sleepy, not just tired. So getting in touch with what those cues are, and maybe going to bed, it goes against common sense, but going to bed a little later and getting up at the same time as usual can help some people with falling asleep or awakening issues. And then finally, from my perspective, it's thinking about the environment around you. So if you're prone to hot flashes, if you're prone to any sweating, think about the bedding that you're using. Is it absorbent? Are there moisture wicking things that you can be using? Are you sleeping with too many layers on you? Are you drinking too much caffeine or hot beverages close to bed that can worsen hot flashes? And then there's great technology, cooling technology for mattresses. So there's all these different mattress pads you can get that are cooling that can help with hot flash at night as well, just to keep the environment nice and cool and dark.
Brilliant. Really simple, really practical.
Absolutely. And I would agree with all those, and particularly around that not going to bed too early. So something that I see in menopause in particular is often women are just so exhausted and tired, and they think, right, I am going to give myself the best possible chance, and I'm going to bring my bedtime forward, and I'm going to go to bed early. And what happens then is either they can't fall asleep, so their body's just not quite ready enough, or they fall asleep, but then they wake up because it was really too early, and they can't go the whole night through. And you get this horrible chunk of time where you are awake in the middle of the night. And then you might get this kind of bit at the end of the night, a nobble, where you're suddenly exhausted again and fall asleep. And actually, you've been trying to kind of be in bed for about 12 hours and you haven't managed to be asleep for much of that at all. And so I think I always say, please don't try and go to bed too early. Later, go to bed later and wait till you feel really that sleepiness, exactly as Shelby said. And the only other thing that I love a little bit of before bed is that racing mind. Try and get it all out in some way before you go to sleep. So, you know, if there's a way of spending a bit of time getting down your worries onto paper, writing, journaling, getting those things down, just and saying, I'm going to leave you there. You know, nighttime isn't the time for that. I'm going to leave you there and then go into bed. I find that really helpful.
Yeah, there's an actual technique called worry time. So it's spending 20 minutes, not right before bed, but earlier in the evening or during the day, where you literally just write everything that you're concerned about on a piece of paper. I have different options for it listed in my book, but the simplest is just write everything out for 20 minutes. When the timer goes off, you're done. And then you say to yourself, not now during worry time. So you're allowing yourself at night saying, I will think about you tomorrow during worry time, but I'm not going to think about you now. And the more you practice that every single day, it gets easier to let go of the worries because you're going to think about it, just not at all times.
Love it. Love it. Any thoughts on, do you like meditation as something to help kind of clear some of that clutter?
I personally love meditation. I think I use a lot of mindfulness meditation, which essentially is just noticing when you're going off topic, whatever you're trying to focus on in the moment, and refocusing, doing it over and over again. And the way that we actually use meditation in sleep medicine is I prefer people to meditate during the day. So you spend 1 minute, 5 minutes, whatever you can do, where you practice some meditation with an app, without an app, because the more you do it, the stronger you get at basically being able to notice when your brain's doing this and letting it go. So you can do the nighttime meditations, but I don't feel like they're always so effective for everyone. If you do it during the day, when your brain is busy at night, you can let things go a lot easier. So you're putting in the gym work for your brain during the day.
So we kind of talked a little bit then about, I guess, what we call that nighttime sleep hygiene and put some definition on that. What about during the day then? Are there things that people can do daytime in preparation for the night ahead?
One thing I would say is about actually the waking up time. So although I don't like that set bedtime where you force yourself to try and go to bed, you know, even before that sleepiness occurs, What you can control is that waking up time. And actually, if you are struggling with sleep, it can be really helpful to try to have a really consistent waking up time, and not for that to be too late. Because what that means is you actually wake up early enough that your body has time to build up its level of sleepiness and what we call it sleep pressure or sleep drive by the evening. And actually, if you've had a sleep problem for any length of time, your sleep drive and pressure are quite low. So you really need to boost that up somehow. So I think a consistent waking time is really good. Literally, I will get people to set an alarm and try to do that as every single day if they can.
Great. Okay.
Light. Get some light exposure in the morning. So right when you get up, don't just lay in bed for a while. Get up after 5-10 minutes. Open up your shades. Even on a cloudy day, it's beneficial. Try to eat in front of a window if you can. Just try to get light exposure because that helps to set that clock for your body.
1,000 steps, girls. Get out there, get some fresh air and walk. Yeah, absolutely with you on that one. Right. So now, Zoe, I have also heard you in the past talk about something that happens when you exercise that kind of helps get the preparation for sleep later in the day. Do you want to just say a few words on that one?
Yeah, well, exercise is brilliant for lots of things, helps with our mood, helps with our sleep. But I think what you remember me talking about is that idea of sleep pressure or sleep drive. So we have this kind of substance that builds up in our brain from the moment that we wake up, and we want it to be as high as possible. And when we go to bed at night, it will really help us fall asleep and stay asleep. And the ways that we do that is, number one, making sure we're awake for long enough, but also by being active. So it's a kind of byproduct of activity, and physical activity will help boost those levels, as will cognitive activity. So, seeing people, socializing, doing work, all of those things. But the more physically and mentally active we can be, the more we're boosting that level. And the problem is, when you're really exhausted and fatigued, often you don't really feel like that. So you're saying something really hard to someone, and we know that, we know we're saying, even though you don't want to, it can really, really help. So it's trying to get that motivation and understand why it will be beneficial.
Okay, fantastic. Right, now, I think we want to get some questions in. Now, I have a slight issue here in that since my laptop froze, all of my questions are frozen in my laptop and they haven't transferred into my phone.
I've got them here. Yeah, it's fine. Shall I just crack on? So I'm going to start from the top, and some of them we might have answered already, but I'll just start with them. So sleep, I'm not going to say names, I know it's all on there. No. Sleep has always been a challenge, but the past year it's been awful and it's debilitating. What's the highest dose of eutregestan/progesterone you can take as a sleep aid? The coil provides me with localized progesterone, plus I'm on Lenzetto. So this question is really saying, although you're on HRT, so you've got the synthetic progesterone, could you potentially add in some of that natural progesterone, and what doses, right? So all of the evidence we have is, yes, you might benefit from a little bit of that eutregestan. It will be off license, though. You'll need to speak to your doctor because you're not using it for endometrial protection with HRT. But you could try that. What we think is it's not dose dependent necessarily. So if it helps, that's brilliant in the normal prescribed dose, which is 100 milligrams as for a continuous regime. But if it doesn't help, and again, you're going to know in 2 to 3 months if it's going to have any effect, don't try it for longer. If it doesn't help, it's really thinking about those other things we've been talking about. And I would be saying to somebody in this position, look, have you thought actually about a program to reset the sleep, maybe like CBTI? So just bear in mind, I don't tend to go up and up with progesterone. Sometimes it really helps, but it's not a deficiency of progesterone. It can help, but if it doesn't help, look for other things.
Great, thank you.
And then the next one says, I'm very fortunate in that I don't feel like I have issues getting to sleep or staying asleep, but I don't feel fully rested and I still get tired and need to nap sometimes. I've been told that I've started snoring very badly the last couple of years, though not sleep apnea. So I'm not sure if that's impacting and if you have any tips to reduce this.
So my question is, when you say not sleep apnea, has that actually been diagnosed, or are you just assuming it's not sleep apnea because of what you might have heard? Or has a doctor looked at you and just said, yeah, you don't really seem to have sleep apnea? Because that's the thing that we see most. Oh, did I hear someone speaking? Oh, hello? Oh, I thought I heard someone talking. You
I
can write in
think
the
the
chat.
volume's low. Sorry. Yes. Go on. Keep going, Shelby.
So that's the first thing I always say is like, don't just assume it's not sleep apnea. And then we have a lot of the home sleep tests. So if you are kind of, they're good, but they're not always, they're more screeners. So if you still feel like your sleep is unrefreshing, then you could talk and do some CBTI, but sometimes it's hard if you think you're sleeping throughout the night. So there might be something like periodic limb movements, where throat kicking a lot, have been checked at sleep clinic. Okay. So I mean, there are other things that could be leading to like upper airway resistance. There's like a spectrum of sleep apnea too. So I don't just assume there's nothing you can do. I might, if the snoring is becoming an issue, snoring can definitely impact sleep quality.
Yeah, and also if you were wanting to go down a kind of CBTI route, sometimes even though you feel like you need to nap, sometimes it really helps to have some time where you force yourself not to, and it starts to strengthen the quality of the sleep. Because although you might feel like you're sleeping all the way through, it might not be good quality sleep, and so sometimes you need to do a little bit of work around that. So there are some things that still might be really helpful for you there. Another question: waking up around 3 a.m. every night and taking about 2 hours to get back to sleep. So that is so common. I think this is the most common thing that we see in perimenopause and menopause. And I think firstly, it can be quite normal to wake up in the night. So we don't necessarily say, you shouldn't be waking up. It can be quite normal to drift out of sleep and be awake. It's that feeling you can't get back to sleep that can be really painful. And so it's about what to do in that situation. Now, I would tend to say, there's some things you can do to try and help keep your body and your mind relaxed. And I think Shelby's got some fantastic ideas on that as well. But the other thing I would say is make sure you're not just lying in bed for all that time. So there's a real limit to the amount of time you want to be lying there trying to sleep, because your body and your brain start to connect bed with not being asleep and being awake. And so we tend to go on about 20 minutes and say, look, if you're not back asleep at 20 minutes, try to just get up and do something else. Take your mind off it. Stop trying to get back to sleep. Can be really, really helpful, actually. Shelby, what do you say for people that are up in the middle of the night?
So when I see the up in the middle of the night with a large kind of bubble awake, the first thing I always think about is, well, how much time are you spending in bed? So if you're in bed 8 or 9 hours, I don't know for sure with this person, but if you're in bed even 7, 8 hours, but you're only sleeping 6 at night, that sleep restriction that I was talking about sometimes, and you want to kind of do a diary for a week or two to get a sense as to what your average is. Sometimes keeping a set wake time and going to bed later for a week helps to lessen the amount of time you're up in the middle of the night, because you have more of that sleep pressure to sleep through, or you wake up and you go back to sleep a bit faster. So restricting the time in bed for some people can be very useful. The other thing is that wind down time. So if you wake up and your brain is active, whatever you go to bed with on your brain is often there in the middle of the night. So now that you've kind of taken a nap for a few hours, essentially. So I always try to get people to do worry time or a brain dump or something like that in the middle or at the beginning of the night. And then in the middle of the night, like Dr. Zoe was saying, there's something called stimulus control. So you're trying to control the bed only for sleep and sex. So I don't even use the rule of 20 minutes because I find that some people get too hyper focused on the clock. So if you're always looking at 3 a.m., it could also be that you're going through a certain number of sleep cycles and you have a natural awakening, but you've trained yourself to look at the clock. And then I'd say, don't bother looking at the clock. You wake up, if you just get frustrated and you can't fall asleep, usually that's around 20 minutes. So you go do something in the middle of the night without a screen and have those things built in that pass the time earlier on. So don't wait until 3 in the morning to find things to do. Knitting, crafting, reading, listening to an audiobook, whatever, but try to stay away from screens as best as possible.
I think there's also something to do with what we're thinking about when we're awake in the middle of the night as well, because when you are awake, you know, if you know your history is you've been awake for 2 hours all the other nights and you wake up, it's very natural to start thinking, oh no, you know, this is awful. I'm gonna be awake again for 2 hours. And then you see everyone around you asleep. And if anyone else is in your house asleep, you start getting really cross with them. It's so frustrating. How can they sleep and you can't? It's horrible. And the thing is, all of these thoughts, and this is that kind of cognitive side of it, all of these thoughts set off these kind of reactions in our body. So it can drive our cortisol to rise, and it actually puts us in a situation, makes it quite hard to fall back to sleep, because actually you're quite wired at that point, or you get all these worries or negative thoughts that feel like they're filling your brain. So there are also some techniques that you can do, and we quite like techniques where you have to practice these. It doesn't work just, to tell yourself once, but you can practice just to notice what those thoughts are. And you think, okay, I'm noticing that I'm having this thought that this is going to be awful, or I'm not going to be able to cope tomorrow. And rather than thinking, I just wish I wasn't thinking that, I need to stop thinking, I need to get to sleep and think these reactions, you just think, okay, I understand that thought, I'm going to accept that thought. And then you just bring your attention back to your body in some way. And so that might be something like a breathing exercise, if you like those. Or there are some other exercises which are just about bringing yourself back to your body, like relaxing your muscles. There's a good one called progressive muscle relaxation, where you just tense and release different muscles in the body. And it's just about creating this sense of just bringing yourself back, not so focused on all these thoughts, because what we know is our thoughts aren't very good overnight often. They're not very rational. We don't think well. And actually, it's better not to focus too much on them. And so trying to do some of those exercises, it's not about forcing yourself back to sleep and thinking, I must go back to sleep. Just allowing these thoughts can be helpful.
And that's why I add in meditation during the day, because it makes it easier for you to be able to access those skills in the middle of the night. So if you look up, so what Dr. Zoe was getting at was something called cognitive diffusion. So in ACT therapy, if you look up acceptance and commitment therapy, there's this idea that if we have a thought, we become so fused with it that it's our reality, and we make ourselves more anxious a lot of times. So I'm not going to be able to sleep. Why am I asleep and not sleeping and everyone else is awake? So you could do deep breathing exercises. I even have people sometimes sing happy birthday or sing what they're worried about to the tune of happy birthday, because it gives some distance from the thought. It almost makes it ridiculous a little bit. So if you look up cognitive diffusion techniques and practice in meditation during the day, you can do all these sorts of things with a little bit more ease in the middle of the night without getting frustrated.
Totally. And there are a few questions, just so I'm going to race through a bit. But switching my brain off is the problem. And I use earplugs to cut out noise when my mind races when I go to bed. Or if I wake in the night. I've tried meditating, but stress is a problem. And hopefully, we've answered a little bit of that. But also, sometimes white noise, I don't know if you've tried out those white noise machines as well, can be quite good just to have something there to sort of distract you. Yeah. I find people quite like those. So that if you haven't tried it, it might be something to try. Someone else has said, I take Eutrogestan at night to help with sleep, but it's not helping. Can I double the dose? Again, I don't tend to change the dose. If it's not helping, I try to look for other things, other approaches to help. Thoughts on liquid melatonin, similar to other types of melatonin. We talked about that earlier.
Yeah.
And it says, my GP advised Eutrogestan should be taken on an empty stomach. Does taking it with food help with sleep? So yeah, the branded Eutrogestan does say that, but actually different formulations give different advice, and it is very safe to take with food, and it may enhance absorption. So yeah, it's absolutely fine to try that and see if that helps you. And then another question is, how do you get CBTI in the UK? So it is hard. It is hard in the USA. I think it's hard in the UK. It's not easy, unfortunately. We would like there to be more available. There are different ways of doing it. So you can use books. So Shelby's book has got some of the concepts of that within it, and it's a kind of follow along program you can do. There is also an online program called Sleepio available. It isn't free, unfortunately, although in some areas you can access it for free through your GP, so you can ask them about that. Some GPs have got access to CBTI, but they are few and far between. And other than that, you can get it at some private fit clinics as well. So at our clinic, the Good Sleep Clinic, and there are other, you know, a few others in the UK as well.
And if you go to the Society of Behavioral Sleep Medicine, I think it's behavioralsleep.org, there's a listing of people who are certified in behavioral sleep medicine across the world. So you can find someone hopefully in your area.
Doctors, I am going to have to bring us to a conclusion, I'm afraid. I know Louise Bartlett will be ready to start her relaxation yoga session at 8, which would be perfect, ladies, to help if you're struggling. Listen, I mean, we could have gone on for hours. That was absolutely brilliant, and I can't thank you enough for doing exactly what I knew you would, which was keeping it real, keeping it simple, and you know, and actually just getting right to the heart of it. Absolutely brilliant. You are total stars, Dr. Zoe Schaedel and Dr. Shelby Harris. Lovely comments coming in from everybody here saying how helpful that was. You really are friends of Harley Street at Home, and we're incredibly grateful for just having you with us. Superb session. Thank you both so very much. Ladies, if you would like to access Shelby's book, go to our Amazon page. It's listed on there and you can find it straight away. I know Rowena is busy as we speak writing up points that we've talked about this evening that we'll have ready for you as a written resource. So again, the whole team for pulling this together. Thank you very, very much. Have a great evening, everybody.
Thanks for having us.
No, my goodness, our total pleasure. You are absolute stars. Thank you very much, everyone.
Yeah.
Bye, everyone.
Bye. Thank you.